Most people assume the bathroom is a simple, low-stakes part of the day. In reality, a handful of everyday habits are shaping long-term health in ways almost nobody thinks about. Start with the urge itself. The colon moves waste toward the rectum through slow, automatic muscle contractions your body handles without any conscious input, the same kind of involuntary muscle action found in blood vessel walls. When that urge arrives, it's a direct signal that the system is ready to empty. The trouble starts when that signal gets ignored. Delaying a bowel movement causes the rectum to stretch to accommodate the buildup. The nerve endings responsible for detecting that stretch, the ones meant to alert the brain that it's time to go, gradually become less sensitive to the pressure. Over repeated delays, those nerves stop firing until the rectum is under serious strain. This desensitization is a major contributor to chronic constipation, stool that's infrequent, hard, and painful to pass. The consequences don't stop there. Specialists who treat pelvic floor disorders frequently see a connection between habitually suppressing the urge to go and later problems like pelvic organ prolapse and pelvic floor dysfunction. It's a chain reaction. One unaddressed habit setting off a string of related issues. This pattern shows up often enough in general medical practice that it's become a recognizable story. Someone traces years of constipation back to a job where stepping away from a desk felt awkward or discouraged, so they simply waited. None of this means someone has failed if they occasionally can't get to a bathroom right away. That's an unavoidable part of life. The distinction is between an occasional delay and a daily default. When "I'll just wait" becomes the routine response every single time, the bowel effectively gets trained to require an uncomfortably full load before it even bothers sending a signal. There's an important nuance worth sitting with. This isn't about willpower or self-control in the way people often think about health advice. It's closer to muscle memory. Just as unused muscles atrophy, an under-responded to signal system stops signaling as reliably. The body adapts to whatever pattern it's given, for better or worse. The fix isn't complicated, even if it requires a mental shift. Responding to the urge when it appears, rather than treating it as an inconvenience to be managed around, keeps the signaling system calibrated correctly. This is one of the few areas of health where the corrective action costs nothing, requires no equipment, and simply asks for a change in timing. It's also worth remembering that this issue rarely announces itself dramatically. Nobody wakes up one day with sudden, severe constipation from years of delayed bathroom trips. It builds slowly, so slowly that the new baseline starts to feel normal. That's exactly why it's easy to overlook and why it's worth paying attention to now rather than after symptoms become disruptive. How straining on the toilet interacts with the cardiovascular system, and why that overlap matters more for some people than others. Few people realize that hard straining during a bowel movement produces the exact same physiological response that cardiologists deliberately trigger during certain diagnostic tests. That response is known as the Valsalva maneuver, taking a deep breath, sealing off the airway, and pushing forcefully against a closed throat passage. During this maneuver, pressure inside the chest cavity spikes suddenly. Blood flow returning to the heart drops off. In response, pressure-sensing structures inside the artery walls, called baroreceptors, scramble to stabilize heart rate and blood pressure in real time. For someone with a healthy cardiovascular system, this brief spike passes without any noticeable effect. The body absorbs it and moves on. The picture changes for people with undiagnosed heart conditions. In someone with unrecognized heart failure, an underlying arrhythmia, or significant arterial hardening, that same pressure spike carries real risk. Medical case reports have documented instances where straining during a bowel movement acted as the triggering event for a cardiac emergency in people who already had compromised heart function. It's worth being precise about the actual danger here. The toilet itself isn't the hazard. It's the combination of aggressive straining, an inefficient body position, and an already stressed cardiovascular system working together. The goal isn't to fear bowel movements. It's to make the process as effortless as possible so that combination never has a reason to occur. There's also a well-documented cautionary example that, while unusual, drives home a broader point about bathroom safety. Industrial safety records include an account of a worker who handled oxygen-generating chemical equipment for submarine use. He brought a small quantity home, added it to a toilet bowl out of curiosity, left the room, then returned and lit a cigarette while seated. The oxygen-enriched air ignited. It's an extreme case, but it illustrates something simple. Bathrooms often contain chemical agents, cleaning products, aerosols, reactive substances that don't mix safely with an open flame. Setting aside that rare scenario, there's a more common and more relevant issue: smoking on the toilet. Nicotine constricts blood vessels and raises heart rate on its own. Layering that onto a body already managing the pressure swings of straining creates a compounding cardiovascular load. For anyone with existing heart disease, blood vessel damage from high blood pressure, or other vascular issues, stacking straining-induced pressure spikes with a nicotine surge is a combination worth raising with a doctor before lighting up in that setting again. The takeaway isn't to panic about a normal bodily function. It's to recognize that straining is not a neutral, cost-free action for every body. For most people, most of the time, it passes without consequence. But understanding the mechanism, chest pressure spike, reduced blood return, baroreceptor scramble, makes it clear why cardiologists take the connection between defecation and cardiac events seriously, and why minimizing straining in the first place is a genuinely protective habit rather than an exaggerated concern. Next, the conversation shifts to something almost everyone does without thinking twice: bringing a phone into the bathroom, and what that habit is doing to a part of the body most people rarely consider: the veins. Scrolling through headlines, watching videos, or reading messages while sitting on the toilet feels harmless. It's one of the most normalized habits of modern life. But it comes with a physical cost that clinicians have documented consistently: extended time seated on the toilet, especially when paired with low-level, repeated straining, is strongly linked to the development of hemorrhoidal disease. Hemorrhoids are swollen, irritated veins located inside the rectal wall. They can protrude, bleed, and cause significant discomfort. A useful way to think about them: they're essentially the varicose veins of the rectal area. The mechanism behind their formation is straightforward. The longer someone remains seated, the longer those veins stay compressed under body weight and pelvic positioning. Sustained pressure over time is exactly the kind of stress that damages vein structure. The phone compounds this problem in a specific way. When attention is fully absorbed by a screen, awareness of what the body has already finished doing fades. The bowel movement itself might be complete within a minute or two, but the scrolling continues, and so does the seated time, often stretching a task that should take a couple of minutes into 10 or 15. Every extra minute is more time the pelvic venous network spends under load for no functional reason. Pelvic floor specialists increasingly categorize prolonged toilet sitting and the smartphone habit driving it as a modifiable risk factor for hemorrhoidal disease, meaning it's one of the few contributing causes a person can change immediately without medication or a doctor's visit. That's a meaningful distinction from risk factors like genetics or age, which can't be adjusted at all. There's also a useful evolutionary lens here. Humans didn't evolve to sit for extended periods during elimination. The behavior throughout most of human history was brief and functional: a short squat, then moving on. The rectal veins and pelvic support structures developed under those conditions, built for short, efficient use, not prolonged static pressure. Modern habits, particularly the combination of a raised seated toilet and a phone-driven attention sink, ask those structures to do something they were never designed to handle for long stretches. The practical implication is simple. Even if the habit is hard to break, treat the toilet as a task with a natural endpoint, not a waiting room. Once the bowel movement is finished, that's the signal to get up, not 5 or 10 minutes later. This single change, on its own, removes one of the most common and most avoidable contributors to hemorrhoid development. It doesn't require special equipment, a dietary overhaul, or a medical consultation. It just requires noticing when the task is actually done and acting on that awareness instead of letting a screen dictate how long the sitting continues. The next part moves into more serious territory: what chronic straining does to the structural tissues of the pelvis over years, and why just push harder is often exactly the wrong instinct. Of all the habits covered so far, aggressive straining is the one with the most serious long-term consequences. When someone pushes hard and repeatedly during a bowel movement, pressure inside the entire abdominal cavity rises sharply. And that pressure doesn't stay contained to the rectum. It radiates outward, pressing against the bladder, the uterus, the prostate, and every ligament, connective tissue structure, and muscle that makes up the pelvic floor. Repeated over years, this load takes a measurable toll. This is especially true for people who have delivered children vaginally and for anyone with naturally weaker connective tissue. Clinicians regularly document pelvic organ prolapse, shifts in rectal positioning, and a specific condition called recticell, where the rectal wall weakens and begins pushing into the vaginal wall. In advanced cases, that tissue can protrude outside the body entirely, which typically requires surgical evaluation and a specialist consultation. Beyond the direct mechanical strain, there's a feedback loop worth understanding. The pelvic floor is a supportive band of muscle at the base of the pelvis that's supposed to relax during a bowel movement, opening the pathway for stool to pass. In pelvic floor dysfunction, those muscles do the opposite. They tighten at precisely the moment they should be loosening, actively working against the process instead of assisting it. Research reviews on chronic constipation consistently find that a significant share of cases stem from this kind of dysfunction rather than simple sluggish bowel activity. The result is a self-reinforcing cycle. Straining harder causes the muscles to clamp down further, which makes each subsequent attempt more difficult, not less. This is also a good moment to correct a persistent myth about hemorrhoids. Popular belief often points to sitting on cold surfaces, eating spicy food, or catching a chill as causes. Current evidence consistently identifies different drivers: chronic constipation, straining, excess body weight, pregnancy, low physical activity, and a possible genetic tendency toward weaker connective tissue. The relationship isn't always a clean, single-cause line. Bodies are complicated, but someone who strains hard for extended periods, sits for most of the day, and eats a low-fiber diet is genuinely at elevated risk. Letting go of the cold seat myth doesn't help anyone. Understanding the straining and fiber connection actually does, because it points towards something a person can change. Posture plays a meaningful, if often overstated, role here too. At the base of the rectum sits a natural bend called the anorectal angle. Sitting upright on a standard toilet keeps that angle fairly pronounced, which is useful for maintaining control over bowel movements throughout the day. Squatting straightens that angle, allowing contents to pass with less resistance. Small studies comparing standard sitting, lower seating, and full squatting positions have found that people in a squat reported shorter completion times and less perceived straining effort. Separate imaging research using contrast agents has shown the anorectal angle straightens more fully during a squat than a seated position, meaning less muscular effort is required to finish. That said, current systematic reviews are careful to note that this evidence base remains relatively limited, and posture is only one variable among diet, hydration habits, activity levels, and medication use. This isn't a reason to attempt an awkward toilet rim squat. It's simply useful context if evacuation already feels difficult and a posture adjustment is worth discussing with a doctor. The final part covers practical, evidence-informed techniques for difficult bowel movements, along with the health factors worth raising in an actual conversation with a physician. For most people eating a reasonably balanced diet and passing soft stool, a standard seated position works fine. Upright posture, feet flat on the floor, torso tilted slightly forward. The techniques below are meant for situations where stool is hard, fragmented, or difficult to pass, not as a routine requirement for every bathroom visit. Adjusting torso angle. Some people find that leaning forward with elbows resting on the knees helps relax the pelvic floor muscles. Others do better leaning back against the tank or wall in a more upright position, which shifts rectal alignment and can add a small amount of gravitational assistance without added force. There's no single correct angle. The goal is finding whichever position reduces the effort required, elevating the feet. Placing a stable stool or platform under the feet raises the knees above hip level, tilting the pelvis and bringing the anorectal angle closer to a natural squat. Research involving patients with chronic anal fissures, painful tears in the anal lining, found that raising the feet and increasing hip flexion was associated with reduced pain and easier passage. It isn't a cure for underlying issues, but it's a reasonable technique to try, adding stable upper body support. When the body has more fixed points of contact to brace against, physical effort spreads across the whole system instead of concentrating entirely on the abdominal muscles and pelvic floor. Holding onto a secure grab bar or the edge of a sturdy vanity while bearing down reduces the isolated load on pelvic structures. The same principle applies to pressing the feet firmly against something solid. The key requirement is stability. Nothing that could slide, wobble, or tip. These techniques work best as occasional tools, not permanent fixtures. If every bathroom visit requires a footstool, a handhold, and a specific angle just to get through it, that's a signal the underlying cause needs attention rather than ongoing workarounds. Chronic constipation isn't simply how some people are built. Research links it to reduced quality of life, disrupted sleep, worsened mood, microbiome imbalances, and elevated risk for certain gastrointestinal conditions. It's worth a real conversation with a doctor rather than an indefinitely extended coping strategy. A productive conversation with a physician about ongoing constipation typically covers 5 areas. Fiber intake, most people fall well, short of daily recommended amounts from vegetables, fruit, legumes, and whole grains. Hydration, dehydrated stool is harder to pass, regardless of how well the bowel is contracting. Medications, opioid pain relievers, certain antidepressants, iron supplements, and calcium or aluminum-based antacids are all known to slow digestive transit. Thyroid function, an underactive thyroid slows metabolic processes throughout the body, including gut motility, and is often overlooked as a contributing factor. And pelvic floor function when diet and hydration changes aren't enough. Pelvic floor physical therapy, sometimes paired with biofeedback training to help coordinate those muscles correctly, has solid evidence behind it. After roughly age 45 to 50, muscle tone naturally declines and nerve signal transmission slows, adding a cumulative effect on top of any existing medication use or health conditions. Pulling it all together, a few simple shifts make a meaningful difference. Respond to the urge when it's genuinely there rather than defaulting to later. Leave the bathroom once the task is actually finished instead of lingering with a phone, and treat straining as a signal to investigate the cause rather than push harder. Positional techniques can help in the short term, but they work best as a bridge toward addressing an underlying issue, not a permanent substitute for doing so. And if there's visible blood, significant pain, or a sudden, unexplained shift in normal bowel habits, that calls for a doctor's evaluation, not a search for reassurance online. It may well turn out to be nothing serious, but a clinician, not a search engine, is the one equipped to make that determination. This information is meant to build understanding and prepare better questions for a medical appointment, not to replace one.